The prevalence is almost 4 million and causes mortality in about 500,000 patients a year. Cardiac resynchronization therapy is a therapy that's been recently developed that is a specialized sort of pacing system used particularly and specifically in heart failure patients to try to make the heart, which really is just a muscle, a more effective muscle to better pump blood to the body and all the organs that need oxygen. So let's talk a little bit more specifically about what cardiac resynchronization therapy is so that you can follow me for the rest of the talk. CRT, like we said, is a specialized pacing system where instead of pacing usually just 2 chambers of the heart, an upper and a lower chamber of a heart, we now pace 3 chambers of the heart, 1 upper chamber and both lower chambers of the heart. You can do this through a variety of methods. Sometimes you can string these parts of the pacemaker called leads, and we have some leads to show you later, which are the parts that actually deliver the energy to the heart muscle itself through the veins, as you see here in these x-rays of our own patients. And sometimes we ask our surgical colleagues, especially in our little bitty tiny babies, if they could please place these leads sometimes on the outside of the heart. But in sum total, they get 3 leads, which are within the heart, which attach to what we call a generator. This is the battery or the brains of the operation. This is essentially what tells the leads when to activate, when to pump to certain parts of the heart, and at what time intervals to do it. And those time intervals become increasingly important, particularly in this very specialized type of pacemaker. The indications for pediatric CRT are really extrapolated from that of the adult patients and the adult population because heart failure is common in the adult world. It happens to the people who have coronary artery disease. These people have cardiac myocardial infarctions. We hear about that all the time. In kids, they don't get myocardial infarctions. So we don't have enough kids to come up with those indications. So we use the adults, and this is what we come up with. However, it leaves 20% of kids who get these pacemakers don't respond to it at all. That's a huge percentage if you're a parent sitting there and one of your kids falls into that 20%. Unfortunately, unlike the adults who have a low complication rate of only 15 to 19%, the complication rate for putting one of these devices in our kids reaches up to 35%. So not only do you have a high complication risk, you then have a risk, if it goes okay, of it not working. This is a problem, okay? So not only are our kids small, and so things are much more difficult to do in them, but like we said before, their substrate is different. They don't have heart attacks. Their hearts are arranged abnormally. They come out of the womb with hearts that are inverted, only have 3 chambers to begin with instead of 4. And so we've got to be more intelligent about how we go about picking the patients to put these pacemakers in. So we said, well, we have 3 goals, 3 things that we really want to think about. The first is how to pick the patients better, how to avoid having 20% of our patients not do well with this therapy. Then where do we put these leads? As I mentioned, we put 2 leads on the pumping chambers of the heart, but we don't know where to put them. We ask our surgeons, just put them, or we put them wherever we can. So there's got to be more thought to this. And then finally, each patient, like I said, each pacemaker has different timings. We're starting to see that each patient has a unique timing specific to them that won't necessarily work for their next patient that comes through the door. So how do we individualize therapy to each of our patients who comes through the door? Those were the 3 objectives. We took that in conjunction with ECGI. And like I said before, ECGI is non-invasive electrocardiographic imaging. It's a modality used to study and learn about the heart, its electrical patterns and rhythms. This modality was developed in biomedical engineering here at Washington University, and we are actually the only clinical department in the world to have an ECGI machine thanks to the generous funding through the CDA. So what is it and how does it work? What we do, and I'd actually like to take you through this slide one by one, so see if you could follow me here, is we have a patient who we put these electrodes on, and I've brought you one of the strips so you can sit and touch it and hold it. And we paste these strips all over the child's torso, so all along the front and back, okay? And this adds up to about 256 electrodes. Now let's be honest, a little itty baby, maybe 100. but still we try to get all these on. These each record an electrical signal from the body surface. We reconstruct that into what we call body surface potentials. Simultaneously, we take the patient without letting them move and wiggle through those strips, and we run them through a CT scanner. What the CT scan does, it allows us to understand the relationship of the heart to all of those leads we've encircled around the thorax, okay? And once we understand the heart-torso geometry, we take the data from the CT scan, the data from the body surface potentials, and we run it through a proprietary software, again, also available here at WashU, and through that, we are able to create these beautiful three-dimensional reconstructed maps of the heart to truly understand each individual patient's electrical activation system, okay? Once we've started doing this, we realized, oh, we should come up with an index so that we can actually figure out what's normal and what's abnormal. And with that, we created what we call the electrical dysynchrony index. I mention it because you're going to see it on the upcoming slides. And we saw that in normal patients have low electrical dysynchrony indices. 19 to 22 is normal, actually, and we did a bunch of normals to figure that out. And what you're going to see in the heart failure patients is something quite different. I'd like to introduce you to our first patient. This is a 6-year-old boy who has a fairly rare form of congenital heart disease where his right and left sides are inverted. Okay, so the right pumping chamber is instead on the left and vice versa. And he had a standard pacemaker. We know through natural history studies that these patients who get pacemakers do very, very poorly and go into heart failure at a very young age. And sure enough, this kid at 6 years old presented to the clinic and said, you know what, I can't keep up with my friends, I can't play soccer anymore, I don't feel good, I'm not eating well, and his parents were obviously very, very concerned. We looked at his heart, and sure, it wasn't beating well. So we said, okay, let's see if we can do an ECGI on him, and let's see if we can learn about his electrical system. And this is in fact what we found. These are pictures of the front surface of the heart, and here the back surface of the heart. And the color scale that I'm going to show you, red are things that activate early, and blue are things that activate late. In a normal heart, you wouldn't see such wide variability of red to blue. What you would see is a lot of red, yellow, and green. And what we see in this patient is this huge variability where parts activate quite early and parts of the heart activate really quite late. Interestingly, these black lines here that you see, this is essentially electrical scar. The heart is scarred electrically, and the wavefront can't move through in a nice way. And what we saw is this kid's electrical dysynchrony index is 36. This is way abnormal, way higher than 2 standard deviations above what we would expect for a child, certainly a 6-year-old.
Can I ask one quick question?
Absolutely.
Can it ever work backwards, making 2 negatives become positive and just kind of balance one another out? Does that make any sense?
It makes more sense than you realize. And what we're realizing as we're going further and further along in studying these patients, sometimes we're realizing it can be so wrong it works. Yeah. But we might not know that unless we did the study, and then we mistakenly try to intervene and make it better. And I think those are the patients that we're seeing are this 20% non-responders. They're patients that we think we're doing the right thing, but we're in fact making them worse. Yeah. So I actually think yes.